take, by submitting the form, that could take 3 months for it to land on my desk. It's probably gone through 3 government agencies. It's probably cost somewhere in the region of £300 plus to actually physically process that form. What I want to do, my measure of success, would be that fewer people actually have to submit those forms, because it really doesn't benefit necessarily anybody. If we can bring that money forward, and people, rather than people paying, excuse the example, Councillor Hutchinson, just focusing on public transport a moment, if we can bring that form forward, and rather than having someone having to submit £5 on a form, it takes 3 months and so forth, if we can actually give them a bus ticket up front that only actually costs the NHS £3.30, then we've saved a huge administrative cost across government agencies. We're actually getting better bang for our buck within the budgets that we've got, and we're not allowing individuals to experience unnecessary delay in receiving financial reimbursement. That's what we're physically aiming at. And transportation, really, the budgets for it and what we're working through. If we invest in this, and we invest in this right as part of the business case we're developing, all the points we've talked about, all the associated costlier things like people not turning up for their appointments, for example, all of the processing time and cost in these forms, it suddenly starts to make economic sense for us to do it. But it's about raising the profile of transportation itself. I hope that covers the point that you've raised.
Yeah, maybe. I guess, so on the first one about low income, it looks to me like what it actually means is if you receive certain benefits and you don't have any savings, that's how you qualify. So it's probably quite a low threshold in terms of low income.
Yeah.
And I think that's probably difficult, particularly if you are on a low, what I would define as a low income, and you're on sick leave or whatever it is because you've got cancer or something awful like that.
Yeah.
And so I think saying, oh, it's the national scheme, it just feels like that's not holistic enough. And so there's something more about if you've hit a hard time. So if you are, I mean, for example, like if you're on an income of, say, £20,000 a year, you wouldn't be on benefits necessarily. You're on sick leave because you've got cancer, and so your income's gone down. You've still got your rent to pay. You still got your food to pay, and then you don't qualify for this scheme for transport. It's very difficult. So I feel like there's something around more flexibility needed in the system. That'd be my strong view, particularly where, because when you're ill, it's like you're least able to find additional income streams. So I feel like the low income thing, in my view, isn't good enough. And then I guess just in terms of funding the scheme, I can see you can make that economic case. I guess I think it'd be interesting to see how it gets on in terms of progress. But what you didn't say is, I guess the assurance that I would like to hear from you is that if it's over budget at the end of the year, people aren't just going to be turned away and not get transport.
Well, yes, So number one, we're focusing on the healthcare travel cost scheme first to try and make that better and make the low income scheme better. But that doesn't necessarily mean that's where we're going to end. But we've got to start creating a conversation, a discussion with our national body, NHS England, to explain why we're doing something over and above the healthcare travel cost scheme. So there's a degree of regulation that we've got to go through on that. In terms of if it was overspent at the year, well, the need is the need. We don't turn anybody down. You know, there were plenty of budgets at the end of a year, if I'm being brutally honest, that were overspent, and people still get the care that they require. You know, I used to be a commissioner for over 10 years on various services. You know, I've lived the ins and outs of budget management on hospital and outpatient care and so forth. In terms of your early points, and which I've got to address in my initial response, in terms of people with complex needs, whether that's their immune system suppressed or so forth, the criteria itself, when we're talking about criteria change, this criteria change is about ensuring that the most complex, the most needed, the most vulnerable actually get transportation. It's not about trying to take that away from people. So if somebody's getting something because they're immunosuppressed at present, the national criteria isn't saying, well, they're no longer eligible. It's not saying that at all. It's trying to bring together the good practice across the country and say, if you have a significant mobility need, you get transportation. If you have renal hemodialysis, because of the frequency of travel, you can have patient transport. If you've got a medical need, that means it will be unsafe for you, even with friends and family, to get to and from hospital appointments. Then you get transportation. But unfortunately, the unwritten thing that I haven't tried to say is that up and down the country, that people have got examples and studies of use of patient transport that doesn't quite fit into that, where there have been assumptions made from hospital trusts that everybody can have transportation regardless of whether they actually physically need it. And so we are trying to ensure that the service is reserved for the people who most need it from a medical point of view, but that from a financial point of view, we are physically addressing all the points, Councillor Scott, that you've mentioned. We've got a very big ambition there. Yes, there's a lot of people look at me saying, how do they think this will go? And we are being terribly ambitious. I'm being terribly ambitious in saying, in what I'm saying. We've got to think about how we want this to look in 5 years' time. And okay. I don't want people to have to keep submitting forms, for example, and I don't want people to not get something that they need either because they're struggling financially. Apologies.
Okay. All right. Thank you. Thank you. Councillor Kurtz.
Hi, yes, thank you. Morning, Simon. You've probably addressed some of the concerns that I was going to raise, because I was worried that these changes might have affected, the elderly who for various reasons don't have anybody to accompany them, and they've got to have patient transport. And I'd also like to say that I know in my area, the ambulance service does a great job at making sure that people have got into their homes okay, and it's sort of like that accompaniment service that goes with it as well. So I think some of the things that you've said have sort of like confirmed to me that that is not going to change for the most vulnerable and for those that definitely do need it. So that's reassuring. So thank you for that.
Thank you for that.
Okay, thanks. Councillor Rhodes.
Thanks, Chair. I have to support the previous comments that have been made and concerns in various areas about this plan. And we speak a lot about the national eligibility criteria and how basically everybody's expected to follow it. I think criteria up and down the country will depend on the population area and areas of deprivation. I haven't heard anything about that in terms of a follow-on through Andrew's comment about low incomes, etc. But I've written several things down that I'm going to follow on and totally support all the other comments in line with that. The simplistics of it sounds good. The implementation of it for those people who need to know what it's all about has not been mentioned at all, other than they get a certificate. And then where do they get the certificate? Who tells them that they're not eligible? Where do they get the certificate from if they are enabled and empowered to do that? If they're not empowered to apply for certificates for this healthcare costs, who will support them to engage in that system? First question. Second question is, I've just recently attended a meeting of WICA. I'm a member from Wakefield. And I believe the major concern of everybody around this table and at WICA is the availability, has been said, of public transport and the cost of it. I can tell you around Wakefield at the moment, one of the major contractors has actually turned down 20 routes, so there's a possibility of it collapsing altogether. And that's the difficulties when you're speaking about public transport. It's not a sound service for people to be able to connect, as Councillor Hutchinson Collin has said. There hasn't been a presentation to WICA from any consultation you've had with them on representatives from the districts. I've not seen it, I've not heard about it, and I will always come up front as an elected member on behalf of the people. Officers can have as much consultation as they like. That has got to go through a process, a democratic process, and I will be, following this meeting, taking this up immediately with the representative of WICA and the chair as to why any conversations or engagement you've had has not been mentioned to the WICA board. I'm also very concerned, as been mentioned by Andrew as well, about this means-tested approach. And again, the ability of people to actually be able to engage in what is, quote, a means-tested approach. We have, as you know, across several areas, discussions going on about reform and review of the NHS in general, including all aspects of support services and our ambulance services, who have been totally, I will say, doing a fantastic job in terms of the ability and the demand. I also want to know what you mean by engagement. Who have you engaged with? Who have they represented? What public bodies and users in general have you engaged with? And is that engagement in material available for us to see, please? The whole ethos of this is coming from, and forgive me saying this, but it's coming from a financial background, and I really understand that. I really do. But when you have a service that people are dependent on, a bus service that has been previously mentioned that is not capable at present of getting people to hospitals. You have mentioned a dedicated volunteer service and the cost to them to bring people home. We're assuming again that those that don't fit into the criteria, and Andrew has ideally mentioned some, it could be people in casts, it can be people on crutches, it can be lots of things where they need support. What evidence have you got from any of the voluntary sectors in terms of their ability not just hop into the car and hop out at the other end? Because that's a vulnerability. That's got to be part of any contractual obligation. And lastly, in your paper to us this morning, I don't think you've got the report in front of you because I don't believe you said you did, but if you haven't, you have a paragraph in here which actually says what are the implications in this, and you've identified a risk of change in eligibility, some individuals not being able to get there. You've identified a risk in equality and diversity and inclusion, again on the same principle. And you've got here that the recommendations from 21 national review, including the national updated criteria, which were each concerned with improving the service. Now that's 21, we're in 24 now. And I appreciate the demand has increased on this. And we all know about legal duties and responsibilities. But lastly on this, Chair, I think is very, very important. I feel at this stage we've been left out a lot in terms of any engagement. And believe me, having been around in Scrutiny for a number of years and on this particular committee for a number of years, and in shadow on the ICB, I am not and will not ever accept late interventions because any date is coming up that you may have to say you have been in consultation with Scrutiny. And I refer to your paragraph on future decisions and policy making. I do beg your pardon, this phone never stops here. Just let me take this. I only have urgent online.
So could I just, while Council, oh, I think she's coming back. Just a minute. Councillor Rhodes, I put you on mute so that you can answer your call. So you need to take yourself off mute. Thanks.
There you go, Liz. Thank you very much, Chair. You have here in your future decision and policy making that the Transformation Committee in November 24, that's next month, will receive recommendations on how best to implement the national defined eligibility criteria. Okay, so what are those recommendations? We've not been party to them or haven't seen them, other than the verbal report you've given this morning, Simon. I'm not anxious and will not, as a member of any committee, take a written comment on recommendations that will probably then go as a verbal report or maybe a written report of the consultation, so-called, that you've had with Scrutiny. Now, can you tell me, I know I've put down a lot of things in terms of your verbal report this morning, but what I want to know then, when you've gone through those questions, A, you haven't expanded on the risks that you've mentioned here. You have not mentioned at all the future decisions and policy making. And for my part, on behalf of Wakefield, I want those determined or explained before any report goes from this committee through our chair or your good self or from Chris from the ambulance service to let us know what those recommendations are. And I think it's far from acceptable that they've not been mentioned at all, Simon. And I really am disappointed, very, very disappointed in understanding the reasoning why the situation of non-emergency should be considered and to make sure that the ambulance service can cover those most in need. We need to know all the reasoning behind it, not a small paragraph which determines 2 areas of risk and indeed the transformation on future decisions and policy making. Thank you, Chair.
Thank you, Simon.
Yeah, okay. A few things in there, and I'll do my very best to answer all of those points. I think, firstly, and I don't want to sound defensive on this, but I think it's important to speak openly and honestly on this. I started on this on the 1st of April 2024 this year. So previous points I accept and I can pick up those with my colleagues, but in terms of the point around this was from 2022 onwards, why hasn't it progressed and so forth. Unfortunately, I'm not the person to directly answer that today, but I can pick that up with individuals outside of this meeting. In terms of actual potential implementation date, we're trying to plan towards a potential implementation date of the 1st of April 2025. So what we're trying to do in terms of November is start to get committees cited on this, but that doesn't therefore mean that further engagement, further work, further involvement can't happen between now and then. It is unfortunate that there was the election period which stopped certain things and stopped certain periods of involvement and engagement. I'm not using that as an excuse, but you know, if you take from April to now and you take that period out, there aren't that many weeks and months within it. But we take that on the chin. In terms of the points around the healthcare travel cost scheme and so forth, I would hope, I'll just be a little bit stronger. We want to do something more than that. I accept all of the points and the potential limitations and criticisms of the healthcare travel cost scheme. I'm there personally. I'm saying it's not right, it's not enough. But what I'm trying to do is paint that vision at the moment to say, where do we want to be with it? And that comes with the acknowledgement we're not there now. All the points that people have raised, we would wholeheartedly agree on. I think we've got a pretty lengthy report that's before you in terms of pages and detail. But you know, we can always add more. There's always more detail to this because it's such a big, complicated, important matter for people. Our reliance or not on public transport, I think we have to include something on public transport, but that doesn't mean it's the totality of response and the totality of mitigation against the risks that we've identified in the paper. The impact assessments themselves, lengthy documents, do go into a little bit more detail on deprivation, but outside this meeting I can share further information on our analysis of declaration. I can share the business case. I can share all the pieces of analysis that we have. That purely out of kindness, we haven't necessarily included everything within this paper because it would make it probably 5 times bigger than it actually currently is. And number 2, we are working every day on this to try and make this better, and we are doing a lot on this from the starting points that I've mentioned. In terms of engagement itself, at present that does exist and consist of a questionnaire at the moment in terms of our pre-involvement stage and focus groups. But once we've got that information back and we've got that summary point, we will share that, and that will then inform what further involvement and engagement that we actually think we need. So I wouldn't want people to feel that the involvement work that we've described in this paper is the totality of our involvement work. It's the first stage in our involvement work, and that's an evolving piece because we haven't actually got the outcomes from that report yet to then fairly and objectively judge what further involvement and engagement work we actually physically need. I think any conversation around the NHS nowadays will invariably come back to finance at some point. You know, I don't do my job without talking about finances. I'll be honest with you. But I'm a very long-serving public servant and recognise that actually the funding decisions have to be the right funding decisions. You have to invest in the areas that you need to invest in. Otherwise, actually, invariably, you can make things harder than they actually are. What we're looking at is actually how we have a totality of transport offer to our local communities and populations that actually is the right one and will be sustainable over 5 years plus. I think it's fair to say on patient transport services at the moment, along with many NHS services, we have a concern around their sustainability, and we're actually actively looking to try and manage that. And that is difficult. You know, looking at questions of sustainability do raise, and quite rightly, fundamental questions. I do apologise that this is the first time it's come to this committee. I would consider that more just in terms of timings of when we started doing the work rather than any conscious desire not to come to any form of committee.
What about the recommendations that are going forward? Do you have any idea of those at this moment in time?
In terms of recommendations moving forward, no, not absolutely, because we haven't received the report yet from our public involvement piece. We've still got some further data analysis to do. We still have to conclude the business case for the healthcare travel cost scheme. I can certainly say from one recommendation that we'll be strongly pushing for the use of the prepaid bus tickets, and we're looking for the volunteer workforce. I can certainly say that.
All right. Okay. All right. Councillor Rhodes, did you want to come back?
I do indeed. I make no apology for my comments in terms of the public that we represent and the knowledge of our communities, and that's in every community that you've got here today. I also am totally aware, having spent over 30 years in local government, of the pressures on budgets. Believe me, I do, Simon, and on your budgets as well.
Thank you.
And we've seen, unfortunately, through the DASI report, some strong challenges that need to be seen to and delivered. What I do not accept, I am aware of PERDA and the way it fell. And I sympathise with you being in here from April of the year with such a big project to consider. But what I don't consider that should have been happening is and I don't want criticism from you or any of us on anybody who should have been dealing with it, but we have no knowledge of anything back to unless we go back to 2022. Now that's not good enough. And I know we've had issues in between and challenges for you all, but there are a few things you haven't answered. First of all, how do people know they're not eligible, and who will supply the certificate, or how do you enable people through a system again that is totally new? How and where do those patients get to know the non-eligibility criteria?
Yep.
And secondly, advice to patients who are waiting or need ambulances, the non-emergency ambulances, that's got to be one package. It's an advice and of how to engage on what would be a new regime. And you know what? Andrew was right in terms of the level of income. The level of income on maybe a one-parent family, etc., 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 and a cost of 3 buses is not in their ability. It's not in their ability. So I think there's a lot more work to be done on it. And I pity you in a way of having to go through all this. But my last question is this, Simon. Why is it being rushed at this stage to April 25, when at this point in time, you've said the public engagement. I cannot, and I am not aware of any public engagement in Wakefield. I don't know about the other members. Focus groups are one thing. They are not responsible or accountable to anybody. And I say that of GP practices as well. There's been no democratic role within it through representation from any of the districts and through scrutiny itself. If it was our chair or deputy invited to a meeting through the ICB. That seems to be one hand that is not telling the other hand what it's doing. And I want really to know, before Councillor Hutchinson is eager to move a recommendation, why does it have to be April 25 when there is still so much unanswered, still so much work to do on your future decisions and policy making? They have a process themselves within the ICB. But always remember, as democratic parts of the delivery system of the National Health Service, elected members have a decision democratic process. And this is why we're all talking about it now, Simon, that we cannot, and I will not, go ahead with something that seems to have so much pressure on what's got to be done yet. We've had no plan of how it's going to be done or what the issues are to be done. And I sympathise with you, I really do. But can you then answer, what is the pressure that needs to be put on for 2025? And at this stage, are you able to, through our chair, are you able to forward an example in draft of what would be the certificate and who and where the advice would be to the patient?
Okay, thank you, Simon. If you could give those answers, Councillor Jamil is waiting very patiently for a question as well. Thank you.
Yes.
Thanks.
So the certificate on low income scheme, that is a nationally set scheme that forms part of the healthcare travel cost scheme, which in our engagement work thus far, people have said colloquially, it's the world's best kept secret. So there's certainly work to do, and I'm with you, Councillor Rhodes. I'm not disagreeing with any of those points. We are at a certain position that we recognise isn't quite where we want to be. So we want to ensure that people are at least aware of the healthcare travel cost scheme. They are at least aware of the certification. I recognise that that certification and that scheme won't necessarily cover all of the examples that we would personally believe qualifies as low income. I recognise that. We start there and then we look to see what flexibility we can put to that locally. Equally, I recognise from a health inequality point of view, potentially asking people to gain certification and submit forms and so forth assumes a certain degree of ability to navigate a bureaucratic system.
Or deterrent.
Yes, and we are therefore looking at that too. So all these points we would recognise, but I'm going to be honest, we haven't got all of the answers as yet. We're very much running our way through this. In terms of April 25 is a planned start date. Because what we were in conversation with people about is, well, at its very simplest, whenever if a decision's ever made on this, there has to be a certain degree of lead-in time to actually then physically plan everything that's required. So the November and April is simply if, for example, we made a decision, then how many months do we need before we can actually physically be ready to do this? But I'm saying those dates, but I haven't got approval to say those dates because those dates haven't been approved in themselves. This is from a point of openness and transparency, saying, well, this is what we're looking at. This is kind of where we're trying to plan towards. But I don't necessarily expect everybody to agree with that, but that's part of the scrutiny process. And we can take up that away and really look at that and take all of the points of feedback that we've got in that regard.
Okay,
Thanks, Simon.
thanks.
Thank you.
Councillor Jamil.
Thank you, Chair, and thank you, Simon. I think some of my points have been covered in previous questions, but I just wanted to pick up on the public involvement.
Yes.
There is going to be a significant impact in Bradford on these changes, and you've alluded to that in your report, and you've set out the reasons why. The two sort of public involvement types you're hoping to undertake is by way of a questionnaire and some focus groups. Are you? What I'm concerned about is that are you going to be engaging with the right people who are going to be affected by these changes? Obviously, there's people whose English language is not their first language, who most likely will not be able to complete the questionnaire. In terms of focus groups, again, in terms of conversations. So how are you going to overcome these barriers and ensure that the voices of these individuals are going to be heard and taken into consideration?
Yeah, thank you. So from our equality impact assessment, we know how many people use the current service, and in particular the areas which are the saloon cars and what are called the wheelchair one bits, the areas where through conversation with the ambulance trust, we think eligibility criteria, if it was going to have an impact, might have an impact in those areas. We've had to do some quite detailed data analysis, and Chris, forgive me, we can't link individuals who use the patient transport directly through the ambulance service data to their demographic detail in terms of their ethnicity, for example. But we've managed to find a robust workaround on it. So we have, I can share it, we have a framework of how many people use the service by ethnicity, by postcode, by area of deprivation, which therefore gives us our sample size of what we're targeting. So with my public, well, not mine personally, but the involvement team within the Integrated Care Board, they have to demonstrate to me throughout the involvement work that they've actually reached that sample size, that they've got into those areas of deprivation that we know where people use the service. And when I receive that report in about, I think it's 8 working days time, I will then make a decision on that to say, actually, do I think that's sufficiently robust at present? And if it isn't, therefore, we will say to them, actually, no, we need you to do more in that regard. We need you to go more into those communities, more with local stakeholders, more with voluntary protective groups, and any support that any member could give us on that to help us with the local knowledge in that would be very much greatly appreciated, because we know what we're aiming at, and we're trying to actually physically get to that number and that composition. So we know how many people we want to engage with, and we know from how many from this area, how many from this ethnicity, and so forth.
Okay.
Yeah, and any support would be greatly received.
All right. Councillor Jamil, do you want to come back?
No, just to comment, just to say that thank you for that. I appreciate that, and I'm sure the rest of the committee as well. And if any of us can help in that regard, I'm more than happy to sort of link in with you in terms of the Bradford district. Thank you.
Okay, so thank you. So if you could send us that information through by email, we will circulate it, and members can then have a look at it and see if they can be of any assistance in providing help in areas where maybe some more focus groups are needed. I've just got a couple of quick questions. I know we're running out of time on this item, and we've got a couple of other large items to discuss. But you've said that in your appendix A that just over half of the people who use the current service would automatically qualify, and then just under half would not automatically qualify under the national criteria. And so, but also that it depends on definitions. So this is the headline national criteria, but under that there seems to be definitions involved.
Yeah.
And I'm
Yeah.
wondering how local is local definitions. If this is over 3 ICBs, are the definitions going to be the same? Are the definitions going to be tailored for the need within those ICBs?
Yeah, sure.
And why would just under half of the individuals not be eligible at this moment in time? And we've talked about physical mobility, but what about mental health issues? If somebody cannot get public transport because they're having problems,
Yeah, sure.
then in whatever regard, then how do those come under the criteria as well?
Yeah.
Thank you.
Okay, no, apologies. And this might be something in my wording. Sorry, I used to be a mathematician, so it might be me just saying things in a way that isn't necessarily everybody's cup of tea. So just to explain it. So when I'm trying to understand who this might impact from a data point of view, I'm ruling out things that I definitely can see. So if we just go back to the things I said, so we can, in the data, we can see people who've got a significant mobility need because they can't get into a saloon car, or they can't get into what we call a wheelchair one car. So we can take those people out. We also know people who go for renal hemodialysis journeys. So they're the two givens. If we take those two out, we take 50% of the demand out, or 50% of the people out straight away, because 50% is for significant mobility need, it's for renal hemodialysis. It's not therefore to say the other 50% won't get the service, but they have to then go through the medical need eligibility, the individual safety eligibility, and then could be subject to any local eligibility criteria that we put forward. But if we say it another way, what we're saying is we know that 50% of demand is already automatically eligible because it's either a significant mobility need or it's renal hemodialysis. How the national criteria set themselves up and structure themselves in terms of their wording doesn't match the categories of data that ambulance services use up and down the country. So we've had to try and work it out in that regard.
So that brings us then to the definitions, the local definitions,
yes,
then, doesn't it?
Yes.
And so working across the 3 ICBs, etc., how is that going to be local?
Yeah, so in terms of, therefore, the questions that are asked in terms of eligibility, we would therefore want the Yorkshire Ambulance Service to have one set of questions that cover the 3 ICB areas, because from an operational point of view, from their sense, you don't want to be asking different questions to different people based on where they live. In terms of the local eligibility criteria, stuff that, sorry, not a particularly technical term, but any additional points that we add to it, we haven't got to that point as yet. We've had conversations around, well, again, it probably would make sense for that local eligibility criteria to be the same across Yorkshire and Humber. But that's from a logical sense point of view. We haven't necessarily got under the weeds of that as yet and actually worked out, well, against local population need, can it actually be the same across Yorkshire and Humber? We're still working through that.
Okay. Chris, did you want to come in?
Thank you, Chair. And it was just, I think, to I suppose, add something to what Simon's expressing is the overarching principle of the national criteria would be that the impact would be on people who have the ability to travel independently rather than not so. So I think just really to add a little to what Simon was describing there about the groups that are given groups, actually the impact would be on those who have the ability to travel independently, and the algorithm and questions would seek that out.
Yeah, and that brings us back to the questions that we've had previously. So Simon, what about the mental health need then as well? Just quickly, please, mental health need.
Yeah, so apologies. When I say medical need, I am summarising. So the medical need isn't just your physical.
Right. Okay.
Medical need.
It's mental as well. Yeah.
Yes. Apologies for that.
Okay, that's fine. I just didn't want it to be excluded from anything at all. It needed to be in there. Okay, if there are no more points, then
Chair,
yeah.
there are two points that yet haven't been defined, and we really do need to know this.
Yeah.
Sorry, Simon. I asked a question of who is going to decide the eligibility or non-eligibility of a person to get non-emergency transport. Is that the hospital? Is it the doctor, or who? One question. Secondly, on the issue of the future decisions and policy decisions, that is actually saying that the committee in November, this is the ICB committee in November, will receive recommendations on how best to implement. There's two words in that, is recommendations and implement. And we do not have at this particular time what those are going to be. So I'm sorry, if there's no rush and there's no deadline in April, then I think there's some point of reconsideration in terms of knowledge to scrutiny. Are we going to see these recommendations? Are we going to see what the Transformation Committee will say is an implementation date? Because at this stage, I think that's the most important part of this paper. Everything we've said out of the issue of the subject matter, but this is a different subject matter in here. So can we get an answer to that, please? What are the recommendations in November? Because they must be in paper now, being considered for a report. And then implementation. There must be an implementation date that's going to be considered there.
Sure. So working backwards. But when I wrote this paper, the plan was to go to the November committee. As a product of this conversation, that I need to go back to my seniors and talk about that. That plan might subsequently change. I'm not sitting here at present with any recommendations written down yet for that November Transformation Committee. I haven't actually physically started writing that report. That report is due on October the 25th. And there was a series of pieces of work that are yet to conclude in that for me to be able to write that report. So I just want to make very clear, I'm not sitting on a set of recommendations at present that I'm not sharing with anybody.
Okay. All right. So who is going to decide eligibility or non-eligibility?
So in terms of if you're asking for patient transport, then the patient transport will be from the Yorkshire Ambulance Service. For individuals who don't qualify for that and then are maybe potentially seeking financial support through the healthcare travel cost scheme or so forth, then that could be anybody. So I don't want to give a glib answer, but I just want to give a truthful answer. That could be technically any healthcare professional that's involved with that individual. It could be a family member who does that. Literally, that's a national website that you go on and apply to. And I'm not saying, therefore, that's the right thing to do, but that is the truthful answer to answer the question. That's what physically happens now. I can share the web link and people could see that and you apply to that.
Okay. All right. Okay. Can I just summarize then? I think what we're saying is that we don't think your November 2024 decision is probably going to be achieved. I think that's what we're saying, that we think that there is far more work that is needed before recommendations go forward. Is that the general feeling of everybody, that we think that there needs to be some more work on this? And we would like more clarity on what those recommendations are going to be, and to see in more detail what the proposal is. So it's okay about having the national criteria, but under that, what are the local criteria as well, and how is that going to impact on people? I think that is something that we really need to understand in detail. The analysis of deprivation and business case to be circulated, if you could do that, that would be very helpful for us, and that we can have a look at that. The engagement, we would like to see that engagement, as I've said, and we'll share it and we'll help where we can to see where there are gaps. Okay. We also talked about the discussions you're having with WICA, and I think the feeling perhaps is that they need to be more advanced on that. Certainly, from where I sit, it would take 3 buses to get to one of the hospitals that I would need to go to. So I think you have to, and another hospital, if I had to go into Leeds, it would be over 2 operators. So, you know, there is a lot there to be discussed, and how that will work. But I think it's the who qualifies on the low income and how people get help. I think Councillor Scopes made this point as to there needs to be more flexibility in the system for people to be able to get help, because if they're not able to get the patient transport, it is going to cost quite a bit to get to hospital, whether it is by taxi or by bus, and sometimes you just don't have that. You may not have that money available when the appointment comes through, and so there needs to be more flexibility around that. There also needs to be consideration of public transport, because yes, we've all got challenges in that area, and you know, it can be a day trip to and from a hospital on public transport. It can take a long time. And we've also talked about bringing the appointment system in line as well with that, so that if people get an appointment, then it is physically possible for them to get to the appointment. Okay. And also we talked about your equitable access, and Councillor Hutchinson has put something in the chat to say that about support the work being done to simplify the administration of the healthcare travel costs, because you're going outside of the system, aren't you? You're trying to provide a system outside of the national system. The committee stresses that transportation needs to receive a far higher priority in ensuring that equitable access to healthcare is not dependent on the future development of a reliable public transport system. And this is what we've been saying. Serving all the communities we represent, in particular the appointment systems of care providers, need to reflect the practical ability of patients to attend the appointments offered. Because what we don't want to see as well is that people who fall out of this eligibility then cannot get to appointments, and therefore there is even more of a backlog and a length of time that they're having to wait, or in fact that their appointment doesn't get rebooked at all. Yeah. Okay. All right. So have I covered everything there that everybody's made, the points that everybody's made? Yeah. Okay. Thank you, Simon. If you could bring us back that information, we would like to see those recommendations. We would like to know what the criteria is, and we would like to know what the discussions with the other ICBs are, because I think it is important that criteria is. I realise the ambulance service needs a standard set of questions, but it needs to be tailored to need within particular areas as well. All right, Simon. Okay. Thank you for your time this morning. Okay. Thank you. Thanks.
Thank you.
Thank you.
Thank you. Okay, so now we'll move on to the financial plan. And Leslie, thank you for waiting. You're going to go through the financial plan, are you, for us?
Yes. So, hello everybody. My name is Leslie Stokey. I'm here deputising for Jonathan Webb, the ICB Director of Finance. I'm the Operational Director of Finance for Calderdale Place, and I take the lead on mental health as well. I'm here today to give you a briefing on the ICS financial plan for this year and also the latest financial position. I'll try and be very brief, given the time that we've got. So I'm not proposing to go through all of the slides in detail. So you've had the pack, and I'll just go through some key messages, if that's okay, and then I'll have some time for questions. So there's a couple of slides there around the context of NHS funding, and sort of shows that how growth has varied throughout the years, but actually over the last couple of years, growth has been quite constrained. And actually in 24-25, growth has been quite static, even though we've had a real terms cash increase. Inflation has exceeded that quite considerably. So it was just a bit of context really in terms of the financial challenges that we have in relation to NHS funding. What that means for the ICS is that we were allocated this year a budget of just short of 5.7 billion. That's split across a number of main areas, the largest of which is acute healthcare at just short of 2.8 billion, mental health care 677 million, community just over £500 million, continuing healthcare just short of 300 million, and primary care and prescribing as our second biggest area of expenditure at just over 1.3 billion. So there's an awful lot of money going into those sort of 5 main areas of healthcare. The plan for this year, as I've said, is quite challenging, and we've actually submitted a deficit plan this year across the ICS system of £50 million. That's split between deficits within our acute providers in the main of 71 million, and the ICB submitted a plan of a 21 million surplus, and the net of the two gets us to a 50 million deficit plan. Within that ICB surplus, there was a planning gap of 17 million. So really that was a unidentified at the moment in terms of that surplus. So that is obviously a net deficit plan is not where we wanted to be, but I think it's reflective of the challenges that we've had in terms of cost pressures, inflation, and lower growth. We're not dissimilar to other systems across the country. So across the NHS, there's a number of very significantly challenged ICS systems. We are currently developing our medium-term financial plan, and obviously that will be informed by the funding statement. We'll be getting planning guidance hopefully before Christmas. So we will be looking to what the longer term plan is for us as a system within West Yorkshire. We have a number of transformation and productivity programs that we're working on to try and help ensure that we get best value for money and best outcomes within that resource envelope that we've got. And there's a list of those there, but there's some particular focus on areas such as CHC, which is continuing healthcare. If there's an acronyms in there, please let me know. So that's the sort of where we are in terms of the planning stage. Where we are in terms of month 5, so that's August position, is that we're currently reporting a year-to-date deficit of 71 million, and the plan was a year-to-date deficit of 57 million. The plan sort of improves as the year gets towards its completion, so we get to that 50 million deficit position. But as you can see, in terms of the year-to-date, we're about 14 million off plan in terms of making sure that we deliver that deficit position. We are, as a system, still forecasting to NHS England that we will deliver that 50 million deficit plan, but there are some significant challenges within that. The main areas that we're sort of experiencing cost pressure or financial challenges are in relation to slippage or under delivery on our efficiency programs, waste reduction programs, and cost pressures above what we were expecting, particularly on some high cost drugs and devices, and pay pressures as well. We have received from NHS England some non-recurrent support of that 50 million to sort of try and balance us off as a system at the planning stage, and that's helped in terms of making sure that we get that cash into the system. However, it is non-recurrent, so when we're looking at planning, we need to understand how do we get back to a recurrent break-even or surplus position going forward. We're taking a number of actions as an ICS to help look at our productivity and efficiency. WIAT, which is our West Yorkshire Acute Trusts organisation, as a group, have been working with PwC to try and identify specific areas where we can benchmark and look at stretching productivity and delivering more efficiency across those acute footprints. And we're also, as an ICS and ICB, putting ourselves and starting a piece of work which puts ourselves under a level of scrutiny that would be equivalent to an external financial regime from NHS England, because of that they might put onto a system of high risk. So we're not hitting the high risk mark at the moment, but we felt that it's really important that we understand what actions could be taken against the system, and to put ourselves under that same amount of pressure and scrutiny to try and make sure that we're taking all actions that we can to deliver the financial plan for this year. So I'm happy to answer any questions. I think the key messages is that it's pretty tough across NHS finances, and I think there was a number of questions in the previous item as well that sort of alluded to financial challenges within the NHS. So I think hopefully that's been given a little bit of context in terms of the overall plan and then where we are to date. But I'm happy to answer any questions.
Okay, thanks. Can you just, for me, because I don't quite understand. So one of your slides, and it could be me, it could be me. Your key highlight slides says you've got a 21.6 million surplus for the ICB.
Yeah.
You've got a 71.6 million deficit plan for providers.
Yes.
2 of the 5 ICB places are in deficit. So presumably the others that are in surplus are countering the 2 that are in deficit. And 6 NHS providers are at break even or better. So I'm not quite sure where the 71.6 million deficit plan for providers is coming in.
Yeah,
I'm confused.
That's a fair point. Yeah, I think we didn't want to go to too much detail in this meeting, but we have 4 NHS acute trusts that have submitted deficit plans for this year. In essence, the subtotal of those 4 deficits comes to the 71 million deficits. So that's the total of those. In terms of the ICB position, we sort of we manage ourselves in the same way that it's same footprints as local authorities. So we've split our budget across the 5 places within West Yorkshire. 2 of the places are submitting deficit plans, and they are, as you say, netted off by small surpluses in the other 3 areas, but actually the biggest part of that 21 million surplus plan that we put in is actually a planned gap of 17 million to try and get the deficit down to 50 million. So it's not that there's a lot of surpluses sitting in the other 3 places.
I appreciate that. So do the 2 ICB places with deficit correlate to where the deficit is for providers, or do they not correlate?
Not necessarily.
Not necessarily. Okay.
Yeah.
All right. Okay. I'll open it up for questions then. Anybody got any questions on this item? Councillor Hutchinson.
Yeah. Thanks a lot. Lord Darcy pulled no punches in attributing much of the poor productivity within the NHS to lack of capital investment. And capital budgets are always being raided by the NHS to prop up deficits in the revenue budget. Well, they have been for year after year after year, which is why we have such poor investment in our buildings and equipment within the NHS. you say that the operational capital allocation for 2024-25 is being spent in full against the allocation. Will this spending all be on capital projects, or how much of it is being diverted into filling the revenue deficit? My other question talking about the national capital for the new hospitals programme of 92.9 million. I wondered what the breakdown of that spend is between Airedale General Hospital and Leeds General Infirmary, which I think are the two that have not been squashed by the latest review of the new hospitals programme. I do have one other question, but the other area that always gets sacrificed to prop up the acute services is spending on preventative measures. And I was wondering what the picture was regarding these two important aspects of the budget.
So capital being raided for revenue locally is not something that we can do. So that might be a different issue nationally around how Treasury makes decisions around how much money it allocates between revenue and capital. But locally, we get given a ring-fenced capital allocation, and that can only be spent on capital. So there's no capital to revenue transfer within West Yorkshire because it's not something that we're allowed to do. And the capital allocation is stretched without a doubt. You know, you're absolutely correct there, and there isn't sufficient capital. And you know, and as you said, that Darcy's been quite clear on that. But in terms of local decision making, we do not transfer between capital and revenue because we're not allowed to, and also we've not got enough capital, and we're, you know, eventually it ends up costing us more in revenue if we can't invest in the infrastructure. So we're really keen to make sure that we spend and plan to spend all of our capital allocation on capital infrastructure within West Yorkshire. The new capital split, I think that 92 million is actually the a planned capital for West Yorkshire. So I haven't got the split between the new hospitals, but the I think it's Airedale and Bradford Community rather than Leeds that are getting funding for the new hospitals. Bradford District Care Trust, sorry, not Bradford Community. But I'll double check that, and I'll try and get the split of that. So,
because there is a large building site at Leeds General Infirmary that was supposed to include, I think it was women and children service, certainly paediatric services, that was sort of cleared and some work started.
Yeah, so
yeah,
Councillor
so it might
Scopes
not be from the new hospital. But,
yeah, so Councillor Scopes
programme.
has indicated. Councillor Scopes, did you want to come in on this particular? No, okay,
No,
sorry.
we did talk about this particular item at Scrutiny on Tuesday, so I can come in on it in terms of background if that's helpful. But I think ultimately it's a decision that we don't know the answer for the new children's hospital yet, and we as a Scrutiny Board in Leeds agreed to write in conjunction with the Executive Board of Leeds City Council to the Chancellor and the Health Minister to say we think we need it. But it's a programme that's under review at the moment. Yeah, Angela might be able to give a bit more detail if you want, like some of the more of the background. Thank you.
Okay, does that answer your point, Councillor Hutchinson, about Leeds? Yeah.
Yes,
yeah. Okay, sorry, Leslie, I interrupted you.
No, that's fine. And I can't remember what the third question was. Sorry, Councillor.
It was about spending on preventative or services to prevent ill health, which always gets sacrificed to the demands of acute care?
Yeah, so yes, so it's we do try and invest in our community services and prevention in terms of pathways that prevent admissions into hospital, but also in terms of working really closely with our public health colleagues as well. And the ICS has taken a decision over the last 2 years to ring fence specific new investments to focus on health inequality. So we work with each of the councils in relation to that budget as well, which is in addition to the sort of prevention budget sitting within the public health functions. Obviously, we're doing a lot of work in terms of population health management, and we do recognise the importance of prevention. I think it's just at the moment, you know, and looking at our medium-term financial plans, making sure that we can prioritise that balance between prevention and what we need to invest in the here and now. It is something we're very mindful of, and we work very closely with our public health colleagues on. Sorry, you're on mute.
You know, Councillor Scopes, did you have another point you wanted to raise?
Yeah, I've got 2 comments and a question, if that's all right. So I sort of echo the preventative comments that Councillor Hutchison made. I think prevention is the only way that we're going to manage to financially support the health of our nation. Just for information, so in terms of the capital shortfall, so Lord Darcy wrote a summary letter of his report, which isn't quite as long, and section 17 of that report says there's a 37 billion shortfall in capital funding. So I think that it is relevant, but it's not necessarily our gift to fix that problem. I think that's the point you was making, Leslie, but it is profound and it is a problem. I guess just when you're setting, the question is around when you're setting the financial strategy, do you look at where the longest waits are? And the reason I say that is it's become apparent recently in that sort of, for example, neurodiverse waiting lists for assessments. Waiting is horrendously long. Sort of, we're talking over 2 years. And I guess, have you done any work on where the long waiting lists are and sort of tried to target funding in those areas where people are waiting the longest? Thank you.
Okay. Just in relation to prevention, I think you know, it'd be remiss of me to sort of not point out as well that within that sort of primary care 1.3 billion that we're spending, we invest a lot in terms of our primary care and prevention agenda as well. In terms of targeting of waiting lists and funding associated with that, each of the places across West Yorkshire will work as part of their financial planning and prioritisation process to look at the priority areas and how to address that. And I think we've got a whole, there's a West Yorkshire-wide neurodiversity work programme that's been working quite actively on looking at neurodiversity weights, what's causing those, how much we're spending on them, etc. And even though waiting lists are still much higher than we'd like them to be, we have been spending more and more in relation to neurodiversity. So I'm involved in that work programme, and I think even over the last 2 financial years, the spend's almost gone up by 50% in relation to neurodiversity assessments, from about 8 million to 12 million. So there's a significant amount of money that is being invested. Unfortunately, demand is exceeding both capacity and resource. So it's not just finances that is a constraint in terms of waiting to list delivery, that's the capacity within the system, both across NHS and private sector, to help deliver and address that waiting list. So it is, I'd say, is a key priority in each of the 5 places, and it's recognised as an issue. And unfortunately, it's not something that I think we'll be able to resolve overnight.
Okay,
sorry, just I guess that was an example of a sort of a wider question, which is, so what you're saying is on this one, you're looking for extra funding to help alleviate the problem. I guess the wider question is, are you looking at waiting times as an indicator of where you need to invest finances?
So each of the 5 places will be looking at waiting times, capacity and resources available in terms of their prioritisation process. And that goes across sort of mental health and acute services, not just sort of neurodiversity.
Yeah, I guess the obvious follow-up question is, how, if we're doing that, I presume we're doing that each year, how's like specific areas got such long waiting lists?
I couldn't I haven't got enough information to answer that in terms of all waiting lists for all areas. I think it will be a matter of, as I've said previously, that prioritisation process, constraints of capacity and resource that will have has led to differential waiting lists in different areas for different specialties.
Okay, maybe that's some information we could get to help answer that point. Yes, I think that's perhaps some information we could ask for, Leslie. Thank you. Councillor Coates.
Hi, Leslie. On the slide, key financial flows, I was quite shocked by the 482 million prescribing costs. And I was wondering if that was net of what revenue was collected in from those that qualify to pay. And
yes,
do you have any other information around those costs? And then on the other programme services, I was wondering, does that include the new hospitals programme?
So this is all revenue budgets there.
Right.
So,
okay.
So 482 prescribing costs is the net charge that we have net of any contributions.
Right. Thank you.
Obviously, that we can split that figure down by place, and we do. We can look at, we look at that information. We've got medicines management leads who look at that on a monthly basis, so we know what sort of drugs it's been spent on. We have particular pressures around some high cost drugs or drugs that are in shortage. The price goes up and can vary on a month by month basis. So you've got an awful lot of information around prescribing costs. The other programme services are just, I think it's just the balance that's being grouped. The new hospital programme is capital, so that's completely separate from that. Right. This is revenue budgets. So it'll include grants and lots of other things which sort of group together. I think it's just no single one of them's big enough to sort of highlight here.
Okay, thank you.
Okay, Councillor Coates, yeah. Councillor Rhodes.
Thank you, Chair. Hello, Leslie. Key message revenue positions. On the second bullet point, you've actually mentioned above that there's a shortfall adverse variance of 14.3 million.
Yeah.
And you've given the main reasons are slippage on delivery of waste reduction stroke efficiencies. Can you just explain what that is, please?
So as part of the planning process, when we're doing our financial plans, we have and all organisations have this is a target to make savings on particular things. So each organisation will identify areas that they can target to make savings. So, for example, in our prescribing budgets, we will try and make savings by working on a particular programme around, reducing waste in prescribing, moving to cheaper alternatives, etc. So that's one example of what a waste reduction programme would be.
Excuse me interrupting,
Yeah.
Leslie. It says you have 5 adverse variances here. So when we say waste,
Yeah.
the definition of waste is in relation to, if I understand what you've just mentioned, prescribing. Are there any other waste efficiencies reductions within the places across the district?
So across the whole of, the 11 organisations, they'll have their own individual waste reduction and efficiency programs. So it's not just about prescribing. It'll be just areas where we've identified there's an opportunity to deliver things more efficiently and reduce the amount of waste that's in the NHS. So that's a generic term. It's not clinical waste. It's just around not wasting our resources. Yeah,
I appreciate that. And it's offset in part by an improvement in the elective recovery funding. Well, that has to be welcomed, because that's been a real bone of contention in terms of those needing elective surgery.
Yes.
I've gone over a page, Leslie, in revenue position, agency ceilings. There's a heck of a lot of money here for an agency ceiling by the NHS England, with a plan, etc., to reduce it. Is that agency funding relative to any particular parts of the delivery of NHS, such as Andrew has mentioned, in terms of neurology? I'm aware of it within Mid-Yorkshire. Is that agency ceiling to cover really primary posts, or is it a generic word again for agency ceilings across the patch?
So the agency
delivery.
Yeah, so the agency ceiling is basically a cap that NHS England has set as a target. And that's per organisation. So, Mid Yorkshire will have one and CHFT will have one. So that's basically that if you went over that cap, that ceiling, you'd get into trouble for spending too much on agency. And there's a lot of agency control documentations. It's not targeted towards specific posts or specialties. It's an organisation-wide target around a bit of grip and control, and not going and spending too much on agency. In West Yorkshire, we're delivering better than the ceiling, and also better than the plan that we'd set at below the agency ceiling level as well. So I think it's an indication that we are managing to manage recruitment processes and reduce the need for agencies within our hospital.
That then brings me back to part of the initial question, Leslie, if I may.
Yeah.
Is there a definition amongst that spend on agency of how and where it's spent? Going back to Andrew's question, and my knowledge will say of neuro as an example, how is that prioritised? Each local place will obviously have its methodology on its own information. And all that information then is sent over to the ICB board for general information in terms of budgets.
Yeah.
Now, in case of the financial implications that there are in this budget, who defines what posts are ones that should be advertised in terms of the need of the service? That's down to the local place in recognition of their own trust. Is that the way it works?
Yes.
That's fine. Now, the other thing that comes to my mind, everybody's going through budgets, Leslie. It's a horrific time with the challenges that people are facing. You've actually got PricewaterhouseCoopers being your consultant. They don't come at a cheap penny. And in terms of their finance review, are you halfway through it? When did it start? When is it going to finish?
So PwC have been in for about 2 weeks doing that piece of work. They've got another 2 to 3 weeks to go. So we'll see the output at some point after that. And they're looking at all of the 11 organisations across West Yorkshire.
Okay. And then could you just give us a little brief report terms? What are the systems with high financial risk?
So I'm not sure across the country who's been sort of notified that they're a system of high financial risk. So NHS England will make that decision based on a number of criteria in terms of the in-year delivery of each of the ICSs across the country. So I'm not aware of the whole country who's been put into that system. I know that locally we haven't been put into the category of high financial risk, but given our adverse variance against the plan and the fact that we've got a deficit plan is why we've taken that decision to put ourselves under that regime already, and to indicate to NHS England this is something we're taking very seriously.
Understandable that actually you're actually having an internal review yourself by an external organisation. Understandable. And when we're speaking about having to deal with a deficit and reductions, etc., and efficiencies, in your revenue consequences overall, is within your system an analysis of what the revenue consequences are of direct medical staff report, etc., the work of medical needs within the system? And is there a methodology within that of revenue, what the total cost of revenue of management of said systems, non-medical management of said systems across the patches are, that gives an overview of revenue consequences to deliver said systems? And if there is within the scope of PricewaterhouseCoopers the ability to actually look at both scenarios within the budgets and the constraints that you're in.
I think you're sort of saying if do we have an analysis of sort of frontline medical staffing costs versus management costs?
Exactly.
Yeah. So that information is produced and it's reported through to NHS England all the time on a monthly basis. So it's something that is regularly collected, that analysis between, they call it clinical and non-clinical. I'm not sure whether or not PwC will make any recommendation around altering of that split. I can't predetermine what they will draw out as an outcome, but I know that we are looking at all sorts of national benchmarking data, which will indicate if we've got staffing levels correct. So I imagine that is something that they'll be taking a view on, and if there's any opportunities in each of the organisation to get more efficiency from the paid costs and the paid budget.
I think what Councillor Rose is trying to ascertain, Leslie, is do PwC have a brief to look across the board at everything? Is that what you mean, Councillor Rhodes? That they're not just looking in one area, they're looking across the board and making recommendations in their terms of reference. Yeah,
that's exactly, Chairman, if I may, Leslie, that's exactly, Chairman, why I veiled my question. Yeah. Because surely you cannot have a systems analysis of an organisation without knowing what the split is between medical and non-medical services within an organisation. If you're actually looking to have efficiency savings, it goes across the board. And if I understand right, then, Leslie, you're not aware that in terms of reference that PricewaterhouseCoopers have now been given, they're in the authority, you say, for 2 weeks and probably another 3 weeks. From what I understand of my veiled question is that you don't believe that that's within their remit to actually look across the board?
No, sorry.
Have I misunderstood?
You misunderstood. I'm not familiar with the detail of the very specific detail of what they've been asked to look at. All I know is they've been asked to look at total expenditure in each of all of the organisations, and the processes around managing expenditure within each of the organisations. So that would encompass both pay and non-pay, and they will use benchmarking data to identify opportunities. Now, that might be in clinical, it might be in non-clinical. I can't predetermine that outcome, but I don't believe that they've been asked to exclude any part of expenditure in their review.
So finally, Chair, when we do get some sort of report on how the future of this financial report we see today, Leslie, is panning out, we may be able to see what the situation is after the PwC have been in the authority and how you're going to manage your expenditure. Bearing in mind, when we look at the Darcy report and indeed the emphasis on preventative medicine, then there may be some changes that may be coming down the line, but we can't see through a glass ball at this time, can we, love?
No. And I think that the regime that we've asked them to do is very much based on the NHS England regime that they would put under for a high risk system. So it might not encompass everything you've said in terms of the longer term, strategic, what we need to do. It'll be much more focused on that checklist that NHS England use for high risk systems.
Yeah, and I guess, Chair, in general, then, from the information, and thank you very much for being here this morning, Leslie. I guess from the information we've been given, each of us in our own place may have some consideration given to agenda items as updates in terms of the budgets for the future. Thank you, Chair.
And that's what one of my suggestions was going to be, that following this report, places may want to look more in detail at some of the items that are on that within that report, more locally to them. Thank you, Leslie, for being with us. I think we would want to see, as we've said, we want to see more on prevention going forward, but we understand that at this moment in time that you're undergoing this review, and I think from a scrutiny perspective, I think we'd like to see what that review encompasses and how and what the recommendations are from that. So I'll have a discussion with Ian about that, Leslie. Okay.
Yeah.
All right. Okay. Thank you ever so much for that, everybody.
Bye.
Thank you.
Thank you.
And so moving now swiftly on to the maternity and neonatal system update. Debbie, you're here for that item. Thank you for being with us today.
Good morning. Yeah, so I'm Debbie Gibson. I'm the Director of Midwifery for the West Yorkshire and Harrogate Local Maternity and Neonatal System. Obviously, I know you've seen the paper in advance, so I just got, do you just want me to give a few highlights? Is that what we did? Yeah, so I gave a bit of background in the paper just about what our role is. So we're essentially the maternity neonatal arm of the ICB, and that role is part transformation, part oversight and assurance. And we utilise the 3-year delivery plan and associated papers to define our work plan for that. And we gain our oversight and assurance through outcome data and survey data, through our perinatal quality surveillance processes, and through feedback from service users and established working relationships that we have with all our provider services. We support trust wherever possible, working collectively where appropriate to improve outcomes and experiences. And we respond to early warning signs of issues by working directly with trust as needed. So going on to, I think it's specifically asked for some information on our current data and for the progress against ambitions. So the data that we utilise predominantly is the Embrace data, because that's the gold standard, but obviously we note the time lag with that data. We do look at local data to give us that early warning sign of what's happening and respond accordingly to that. And in response to some of that, we have done deep dives of stillbirth and neonatal death data. We've got some ongoing work looking at neonatal deaths at the moment, and that's due to be finalised and presented at our LMNS board at the end of November. And we've identified additional complexities when we've tried to break down that data a little bit more. And we've asked for some modification to the Embrace data to enable us to look at that system-wide picture a little bit more closely. And a response being acknowledged, and we've been advised that they will consider this, but we don't know if or when they will make the changes to that. I mentioned in the report a bit about the Leeds data, because they are our biggest unit and therefore their numbers are higher than others. They do work closely with a similar trusts, and we do look at the data from other trusts to compare that are outside of our system. And they've developed a group of super centres where they link together to share learning and peer review cases. All the trusts within that sort of super group are unique in themselves, in that they offer slightly different services and they serve slightly different populations. Therefore, it's difficult to exactly compare data from one to the other. But the continued peer review of care and sharing of learning is extremely valuable, and then that relationship's really expanding. One of the key interventions that we have ongoing at the moment in order to help reduce neonatal mortality and morbidity is the Saving Babies' Lives Care Bundle. We're on to the third version of that at the moment, and we have quarterly review meetings with our providers to ensure they're implementing and sustaining that implementation of that care bundle. We've got really good compliance across all of our providers. They're all currently over 85% compliance, with some over 90% compliance, and where they're not quite compliant, it's about the audit numbers, that they're not quite at the required thresholds, and some of those thresholds are quite high, and it does fluctuate a little bit on quarter if one audit just drops down just a little bit. But to say, we've got ongoing reviews with that. It'll take a while for us to see the results of that implementation of the care bundle, really. It was first introduced last year, but as things become embedded, it will take time to see that in our data. And so just sort of in summary, sort of the level of deprivation as well within West Yorkshire and Harrogate footprint, it's one of the highest in the country. And we, tackling inequalities in health is a real focus for us. We've been doing some work on that already, but we recognise that we need to move expand that, and we've just appointed just this week the starting post at Health Inequalities Programme Manager, which is really exciting. There's someone that absolutely can own that agenda, and that's as well as our trusts have leads as well on that work. And we're looking at, again, of what have we done already on our equity and equality plan, and what we need to do, what we still need to do, and focusing on improving outcomes for those in greatest need with our system partners. So that's my summary overall, and I welcome any questions on anything.
Okay, thanks, Debbie. Thank you. Do we have any questions on this item? Councillor Hutchinson.
Thank you, Chair. I accept what you're saying about each of the regional tertiary referral centres having slightly different criteria for the services that they actually offer, but a statement has been made that there's a higher neonatal mortality at the hospital trust than the other acute providers. I do think we need to see that in context with the mortalities at places like Newcastle, Manchester, Liverpool, to be able to say, well, yes, that's within the same kind of ballpark or as these other areas, or sort of, a lot better or a lot worse. I think to just leave it hanging without that comparison is probably not good enough. I do have another couple of questions, if I may, but I'd like to hear what you thought about that.
Yeah, and that is something as part of this deep dive review. We are looking at all the different sources of data, and we're working with the neonatal operational delivery network as well to look at what data they have to try and ensure we're getting that comparison, so that we should have that information. I was just trying to highlight the complexity of doing that, but that is absolutely something that we're trying to pull together. Is to say, so where are they in position with others? And one of the things that's come out, one of the things that's come out of those meetings is that other sites have said that they've sometimes been the ones that's got the higher rate, and it does seem to fluctuate. But that's something that I'm trying to unpick, that initial those comments.
Given that maternal mortality rates and neonatal brain injury rates are two of the areas that you're focusing on, it makes it quite confusing when we're told that there isn't really the data to actually monitor those, to know whether we're actually making progress in those areas or not. And so, you know, it begs the question almost as to why they were set as areas of priority if we can't actually assess whether things are getting better or getting worse.
Yeah, and I think for the brain injury data, it was something that we could collect historically, but we've not been able to for a number of years. And we're not alone on that. We're not the only system that's not able to measure that. And so we've explored sort of ways we can do that. We are unable to do that at system level. So it really would rely on the data collection from NHS England to be able to get that information.
And is that being sought?
I'm personally not actively seeking that. It's a measure that they have set, and so it's not something I'm actively seeking at the moment.
Okay. Finally, we're told that neonatal deaths from congenital anomalies is the main reason that neonatal deaths have increased. What is being done to actually reduce that potential increase in deaths from congenital anomalies, in terms of preconception measures, in terms of monitoring during pregnancy, in terms of making sure that the population most at risk are encouraged to engage with the antenatal services as early as possible? You know, it's not really adequate to say this is why it's happening and then just leave it hanging.
So there's two answers to that. The first part is actually about the choice of the woman and family. So we do have a lot of families that absolutely do engage early. They know they have an abnormality and they choose to continue their pregnancy and have a live birth and spend some precious time. It's absolutely about choice. And those numbers have increased recently, and some trusts have specific pathways to support that informed choice approach. So that absolute, you know, and I haven't got exact numbers on how many families it is, but we do know that we have got specific pathways that are fairly new that have increased that rate, and that's something that we're looking further at. How do we quantify that and compare to previously? The other element about that preconception counselling, we do have some areas where we know that there are particularly genetic conditions that are linked to some close relative marriage relationships, and we do have some work ongoing to develop some roles with that. So we have some additional funds called the Culturally Sensitive Genetics Services, and we have funding for Kirklees footprint and for the Bradford District and Craven footprint to provide a close relative marriage midwife roles that would link with those families to ensure there's education for staff to ensure there's adequate screening in the antenatal period, and to provide support to families to enable them to make informed choices in their pregnancy or after, when they've had an affected child, and about future pregnancies.
Councillor Hutchinson, yeah. Councillor Blackborough.
Yeah, so I think you've answered my question. I was just about to ask what additional resources are put in place for those who have lost babies prematurely, but I think you've just literally just answered that part. Albeit the hard to reach where there's inequalities, it does still concern me in terms of the support for those families. So what, you know, I suppose the question is still relevant as to what additional support is going to be put in place for those hard to reach.
So we have all our provider services do have 7-day bereavement services available. They all have bereavement midwives that are specialist trained that do link with families and give them additional support. And that's not just in that postnatal care period. They follow those families. They have sort of They have groups where they come together for shared support, and then they will follow them up through future pregnancies, and then they will have sort of marks on their notes to identify that they've had a previous loss, so they get additional care and support and appointment, additional counselling to help them in future pregnancies. So that's the service that is offered to anyone that does have a bereavement. We are aware of our health inequality gap. We know that we have we do know that the women from the Black and Asian backgrounds are more likely to have adverse outcomes, and we have got. Everywhere is aware of that and has got particular work streams on that. We've just received some additional funding this year for enhanced continuity of care measures, and we're using that for things such as there's roles that are called a maternity befriender role, or other specialty support worker roles, which are roles that are designed to link with those most deprived families or those that need that extra support, to give them extra appointments, an extra named person that can support them through their pregnancy journey. For simple things like, just ensuring they know what their appointments are, helping them to get to appointments, etc., and any other additional resources, and helping them navigate the complexity of their maternity journey. That's just evolving. We also have we pointed to health equity roles within provider services as well.
Okay. All right. Can I ask a question then on maternal mortality? I understand from the paper, etc., that the numbers are such that you need a regional approach to undertaking a review of maternal deaths across the region. But it says the start and finish date for this review has not yet been confirmed. What discussions are you having regionally to try and bring that forward? Is progress being made as to when that review will happen?
So I was informed verbally last week that it is definitely happening, but that's all I've had. So I have a monthly meeting with our regional team, and I first raised this potentially about 6 months ago and asked for a wider help, because we know that if we just looked at it with our system, we may not have the right expertise to do it justice, but if you've only got a few cases, it would really benefit looking wider. And I have asked for monthly, when I give my update about that. They have had some restructures in our NHS England regional maternity team, and I think that's maybe put the delays, but I have been told that they are starting that, but I've not heard any more at this moment in time.
Okay, I think
it's not very helpful, sorry.
No, that's okay, but I think as a scrutiny committee, we would like to know that information. But from the regional, if you could ask the regional that the scrutiny committee are asking when that will start. Thank you. Councillor Rhodes.
Thank you, Chair. Hello, Debbie. Great amount of detail and work. Thank you very much for your report. You've mentioned, and it is something I ask everybody on every report, when the word is said support, I always like to dig a bit deeper to know, quote unquote, how do they get the support? Who refers them? Is it within their own catchment area? Is it within their own trust? And you mentioned social workers. I mean, we're all aware that maternity services over the years have been very short in terms of midwifery, and indeed some social work support as well. So could you just give us a little definition of the progress or process of support, Debbie, please?
Yeah. I don't remember mentioning social workers particularly. I may have mentioned other social roles, but the way it would happen is it varies. So we get various information from trusts. We get data from local dashboards. I attend. We have perinatal quality surveillance meetings that happen at trusts, and they present lots of information there. And I also link with. We have ICB place leads and quality leads as well that link with the trust. And it may be that collectively we see some things that we just is in that data that is a little bit concerning, or it might be from our service user feedback, or it might be in response to other reports that come. So for example, every year there's the CQC maternity patient survey that happens, and when staff surveys come in. When we get that data, if we see any concerns in that, we would absolutely reach out to the trust and say, what is your response? I mean, it would be a routine thing that we'd expect to know what the response is, but we would directly reach out to them, and it may be me that initially reaches out to the director of midwifery and the provider. I have a really good relationship with all our directors of midwifery to have an initial conversation about, you know, what are their concerns, what are they doing about it, or what are their initial plans, and then we would jointly together look at, so what else do you need? Have you got it in hand? Do you need other support there? And then I would link with our ICB leads and other system partners to look at what that offer might look like. So, for example, we have, and then the other way it might, I'll go back to the example in a moment, sorry, but then the other way it might happen is that the trusts themselves might directly contact us, and they might say, we've had a slight increase in stillbirths. We don't know if we think it's just a blip. However, we'd really welcome some external scrutiny on that. So they're sometimes invited in, and then a few of us, so myself and some obstetric clinical leads and quality leads would go in and just look at all the cases and say, you've done all the reviews. Is there anything that you've missed collectively? Are there any themes or anything coming out? So yes, that's one example. And then some. I was going to go to examples and I've lost my thread now, but that is one example where it would work. But we might then just organise an additional visit to a trust. We may go in and just sort of have conversations with them, with some staff, depending on what the issue is. We'll link with service users to find out what the issue is that, and then define what they actually need. And it does vary between trusts. So we've had some trusts that we're struggling sort of with some action planning and things. So we sort of went and talked through what they've done well and actually where they could be strengthened and how they can be clear on it's measured. And again, we've drawn people with the right skill set to be able to do that. Does that answer your question?
It does, but the one thing that just bothers me a little bit out of it is the mights and they and if. Do we not have a kind of protocol in place, Debbie, where there's a responsibility through that trust to do exactly what you've said?
Yeah, there is clear, but I mean, we have, as I say, we have the quality surveillance groups, we have our system quality group, which also that information feeds into. We have regional quality surveillance group as well. We do have all that. We do have specific guidance within the quality framework of what we would escalate, but it's about that combination of knowledge from actual data and sometimes software intelligence of when we develop that picture on what we would do next. But we have a good working relationship with our providers. I would expect that they would reach to us, and they usually do reach to us when they start to see concerns in their own data before it comes to us as a surprise, and that's the kind of relationship we have. We don't really seem to get many surprises because we have that relationship. They're well cited on their data, and so it comes that way.
Okay, thank you, Debbie.
Yeah,
thank you.
Are there any other questions for Debbie? No, okay. Thank you ever so much, Debbie, for that. And if you could ask the regional maternity what their plans are for starting that review, please. Okay, because I think it is really important that we do have that review take place. Okay, thank you so much. Thank you. Right, we will move then on to equality, diversity and inclusion. And Fatima, you're here for this item, aren't you? Hello. Do you want to introduce the item, Fatima?
Thank you, and thanks for the opportunity to come and present to the committee. For those of you that I've not met before, hello, my name's Fatima Khan Shah and I am the West Yorkshire Inclusivity Champion, which is a role that is shared across the Health and Care Partnership and the Combined Authority, advising the leadership on equality, diversity and social justice. So the reason why I asked for the opportunity to come and speak to you all today was I've come with some really exciting news, which is that we're developing an equality, diversity and inclusion strategy for the Health and Care Partnership. And one of the reasons that we wanted to come and see you early doors was to sort of give you some assurance about the development process, but also to sort of seek your support in amplifying the conversation and making sure we get this right for the citizens of West Yorkshire, and just sort of having the opportunity to listen to some of your conversations on the last agenda item just shows how important it is that we get this right. So one of the reasons why we think this is really important is because I believe that equality, diversity and inclusion is everyone's business. It's a little bit like HR, where you go to the professional for some specialist advice, but the actual day-to-day implementation is done by everybody, just like good people management. We also are really keen to link this in to the 10 aspirations that we've got in the Health and Care Partnership about making sure that when we're talking about life expectancy, obesity, access to cancer, diagnosis, that we're supporting everybody in a much more inclusive way and addressing some of the inequalities that I can hear members of this panel are so passionate about. What it will also do is really help us navigate some of the challenging circumstances that both our health and care organisations are in about prioritising services for those most in need. And what we're hoping is that this process will help us really maximise that process by utilising the benefits of system working and collaboration and partnership. So as you'll have seen through the paper, what we've tried to do is to develop a process by which we're doing a sort of a triangulation of a number of different elements. One is, most importantly, what we are hearing from the public, and the role of elected members like yourself is crucial in ensuring that we reach everybody, including those that are in seldom heard communities, and that we act on what they tell us. Another element is being data-led. So what is the data telling us? And someone who's got a background in sort of engagement and involvement, and I started my journey as a sort of patient advocate and scrutiny lay member, as well as Councillor Smage will know. And I'm really keen that we use the data and that people tell their stories once, because I think if you speak to members of the public, they're really sick of having the same conversation more than once. Another element, and it's just as important, is ensuring that we address what our statutory and legislative requirements are too. So it's a very delicate balance of triangulating those particular areas, but more importantly, building on what we're already doing. And as you'll see from the work that we've done already in West Yorkshire's Health and Care Partnership, working in collaboration with our local government colleagues, we're not starting from scratch. And the reason why that is really, really important is because we want to develop this strategy in a way that is accessible to everybody and people can really understand the journey that we've been through. So there are a number of phases to this, and we're on phase 1, which is why I wanted to come and speak to you all early doors. We've done a number of events, virtual and in person, really targeting and trying to connect with people of all ages. We've also now, as a consequence of that, gone through the data and identified any particular groups that we've not heard from. And what you'll have seen in the paper are some of the themes that have come through that engagement activity. What we will be doing through that process is then making sure that we're having targeted conversations with individuals that haven't had a chance to contribute for the first time, as well as individuals that have already been as part of this conversation, to see how we can finesse these priorities into both tangible recommendations and aspirations, but more importantly, an action plan that is smart. Because I'm a big believer in the mantra of Elvis, which is a little less conversation and a little more action, which is what our public tells us they want. What we then will need to do is work with our colleagues in all our partnership organisations to identify then how those priorities will be implemented within those organisations, because when you're working in a system like ours, subsidiarity is really important. And one of the things that colleagues have also told us is that, you know, the system and the leaders are behind this aspiration, but the proof is in the delivery through those middle and operational line managers that make it a reality. So just to give you a sort of brief overview of what we've heard so far, most of the important messages are that they genuinely, and the public also agree with this, that fairness and social justice is everyone's business. And obviously, as democratically elected colleagues, you will, of course, will agree with that. But what we've also got to really get better at is listening to the lived experiences of people. And if we reflect on some of the events over the summer, there is something about our local government and our health and care partnership stance when it comes to hate and discrimination, but also violence against our staff or within our communities. This will require us to be courageous and ambitious for the people of West Yorkshire, but we also need to make sure that when we're taking decisions in their interest, that we're doing it based on the principles that I've just described to you. And that will require us to really work on our partnerships and to develop and address some of the issues of trust within our communities and their perception of public sector organisations, because trust is at an all-time low for some of our people within our communities. So what I'm hoping will happen next in regards to sort of the next steps is that we will continue this conversation, and for those of you that are available, we are hosting a live webinar, Wise or Not. I'll let you think about that on Wednesday evening it will be open to everybody in the public to facilitate a conversation on those themes and how we support the strategy to be a framework that will deliver that tangible change that people are very much pushing for. We are also doing some triangulation, like I said, of the assessment of where we are in the data, so that we've got some tangible targets to bring back to you of how we want to make this a reality, and also to make it feel really smart. So what we want to do, and we've learned this from other projects that we've managed in the Health and Care Partnership, is people need hope, but the transformation that we need to give will take time. So there needs to be a balance between those short-term goals to build the momentum and the hope, as well as that long-term transformational change. So that's sort of as brief as I can possibly say, update on the strategy, because I'm mindful that you are running a little bit behind on time. If I may, Chair, just briefly mention the Donna Kinnair review, which is taking place imminently. So for those of you that aren't aware, in the latter half of 2020, in the midst of COVID, the leaders of the Health and Care Partnership tasked myself and another director in the Health and Care Partnership called Sarah Smith to undertake a review into the impacts of inequalities impacting our communities and staff from ethnically diverse backgrounds. We did that review in 3 months. We developed the action plan a month later, and we've been reporting on that action plan to Partnership Board. 4 years on, we think it's a really good time to revisit that review. One, to see whether the progress we aspire to achieve has delivered, but also to explore what more we can do. So that will be taking place in the latter half of this year, and we hope to bring an update on that to Partnership Board. And if you wish, Councillor Smage, we're more than happy to bring it back to Scrutiny too. So I'm going to pause there, mindful, a lot of information, but I know it's been a long meeting, so I didn't want to talk at you for very much. Happy to take questions.
Okay. All right, thanks, Fatima. Can I open it up for questions? Do any members have any questions on the resulting priorities that are coming out of the discussions? Councillor Hutchinson.
Thank you, Chair. One of the important ways of trying to improve patient safety and the quality of services that are being offered to patients is for people to be able to speak up and point out where things aren't going as well as they should be, or where there are risks. But we know that the disciplinary processes within the NHS are often more geared to protecting institutional reputation rather than the safety of patients, and that there's greater likelihood that people from ethnic minorities become the targets of the disciplinary processes within the NHS. The Department of Health back 20 years ago produced a document maintaining high professional standards, which does indicate to employing trusts how they should apply the disciplinary process, which has a huge amount of really good guidance within it, but very few trusts actually apply it. And that may, and if it were applied, some of that discriminatory impact of the disciplinary process may well be mitigated. Similarly, trusts are supposed to have freedom to speak up guardians. So is primary care as well. But because the teams are so much smaller in primary care, it becomes much more obvious who might be actually speaking up and invite retribution for raising uncomfortable questions. So the two things that I would like to see as part of this review is the way in which maintaining high professional standards is being implemented within employing trusts, and whether people really do have access to freedom to speak up guardians in a way that encourages them to point out where the care delivery could well be improved.
Councillor Smith, can I just check? Would you like me to respond after each question?
Yes,
or would
please.
You like
Yes, yes, please.
Thank you. My apologies, Councillor Hutchinson. I thought you'd finished.
Yeah, and my other question was another area for review, which I'm not sure is being included, is the access to health services for migrants within the area. But, you know, particularly they are currently entitled to access primary care and infectious diseases services, but that's not necessarily the experience of people when they try to access those services, but also whether we're actually being counterproductive in the constraints that are being applied to people accessing other health services while they're stuck in our asylum seeking system.
Okay, Fatima.
Thank you, Councillor Hutchinson. So if I may, I'll just respond to elements of them that you've just described. So the first one about the importance of our services being safe and the importance of anybody working at any level from any background being able to speak up and feel comfortable and psychologically safe to do so. One of the elements that we always look at as part of the workforce race equality standard that every trust has to report on is the sort of proportionality of staff that experience discrimination or are more likely to be reported or escalated into the disciplinary process. And the data continuously tells us that there is a disproportionate group of individuals from an ethnically diverse background compared to their white counterparts that are going through that process. One of the recommendations from the Dame Donna Cornier review was to look into the process of as to why that is happening, but also is there more that we can do to support colleagues go through that process and to support managers that are facilitating that process to make it more inclusive, to ensure that there's no inherent bias in that process or structurally embedded advantage, but also that we're making sure that anybody who feels like they need to speak up on an agenda regarding patient safety feels able to do so without fear of reprisal. We will be revisiting that recommendation as part of the review, so I can't answer that question right now, but hopefully next time I see you I will be able to do so. What we've also done working in partnership with those organisations is ask them to think carefully about the process that they have in place for the Freedom to Speak Up Guardian. So though there may be a specific figurehead within the organisation that holds overall accountability, is there an opportunity to have a network of champions from diverse backgrounds who are working in different sectorial roles? So, for example, a porter, somebody working in catering, as well as that senior level individual, just to make it feel much more inclusive and approachable. Not that they're not, but there's also sometimes those inadvertent barriers, isn't there? And a number of our organisations have done that. And it's a model that we're looking to adopt in West Yorkshire. So we are aware of it, and I completely agree, and hopefully I'll have some more information for you on that. I also wonder, just reflecting on what you've said, whether there's an opportunity, particularly within primary care, because as you say, it is very small, it's very segmented, to develop some economies of scale. So that might be something we can pick up during the review of how we can collectively support colleagues that are working in smaller organisations to feel part of a larger process. And that's definitely something I can look into. As your sort of second question, which was the access to services for people that are sort of, you know, asylum seekers and refugees, one of my roles as the inclusivity champion is to be the strategic lead for the Inclusion Health programme, which is a programme that specifically focuses on sex workers, prison leavers, refugees and asylum seekers. I chair a group that looks into the provision of those services, how we're making them inclusive and how we're proactively working with those communities to ensure that they're getting the access and support that they need. The assurance I get in that group is that they're working really hard and that the lived experience of those individuals is positive. But having said that, Councillor Hutchinson, I can't give you the assurance that that reaches everybody, and there's always more that we can do. So if I may, I will take that feedback and go back to make sure that when we have the next meeting, and I've got the briefing on that this afternoon, that we are looking proactively in the areas that you've described so I can get that assurance for you. Would that be okay?
Yep, I'd be very interested to hear how you get on. And if you could also include people who lead street-based lives.
Yes, they're part of the remit too.
Okay, great.
Fabulous. I'll make sure of that. And then if I may, I'll send a note back to Councillor Smage to share with the panel.
Fine.
Would that be okay?
Thank
you.
Councillor Rhodes.
2 quick questions, Chair. I know it's been a long meeting, but it's been very informative and useful, I have to say. One is the issue of equality and diversity. I think there are some people that feel marginalised with that description of issues that may concern them. And it is, I think, useful to understand as well the gathering of data and information. For instance, I'm all for data being used and how often it's updated. But the question is, how are you using the data from large organisations such as local authorities who also have policies in place on equality and diversity? You're wanting to develop a community cohesion between various bodies. But most authorities now already have a community cohesion plan in place. And are you using that information that's out there rather than, starting another platform? I'm conscious that there are at times duplication. I don't think we have the time. I don't think we have the finances to support it. But how much data are you collecting from other organisations on their policies and plans?
Thank you, Councillor Rhodes. Really great question. So the first thing about, whether the EDI approach is fit for process and also whether it supports everybody in an inclusive way, I think I'd be really honest and say no. Because when we talk about equity and social justice, we have to recognise that society isn't experienced by everyone in the same way. So I acknowledge that, and that's the reason why we need to have a consistent approach. In regards to gathering data, part of my role does cover local government, so I'm very familiar with the data sets that they've got. We work with the EDI leads of all the local authorities in this space to ensure that when we're making decisions, it's with the sort of element of a consistent vision of the truth. What I will say, Councillor Rhodes, is in my experience, not everybody measures the same things. So, for example, within the NHS, we have different metrics, we measure different things compared to our local authority counterparts. So there is something about how we try and triangulate sort of apples and apples rather than apples and pears, which is where we are at the moment. So I ask for your patience with that because I completely empathise with your frustration. I am also very frustrated about that. With your point about community cohesion and policy, so one of the benefits of having this shared role across both local government and the health and care partnership is I'm able to sort of look across both. And when it comes to community cohesion, all local authorities do not have a consistent approach and they don't all have policies, is the first thing. The second thing is many organisations, due to the financial constraints in which they operate, also don't have the same infrastructures and the same staff. And what we're seeing as a consequence of that is the manifestation of the social disturbances over the summer. So the reason why we're sort of looking at it is not to supersede or overstep on the role of local government, because actually they've got the connections and the trust of local communities to make this a reality. What we're trying to do is support the infrastructure behind the scenes to make sure that everybody is supporting the same vision. Because the NHS is a microcosm of society and whatever happens outside our doors comes within it. So we've got a role to play in making sure that we support our colleagues to feel safe and included when they're going to work, when they're leaving work. And you'll have seen over the summer, some of our NHS colleagues did not feel safe, and neither did our local authority colleagues, to be fair. But there's also something about how we work with the leadership and establish trust of our elected leaders like yourself to make that a reality. So please be assured it is on my radar. And part of the approach we've got is to create that consistency and to maximise resources. I am not a fan of remixing the same song or doing something differently with the same ingredients. I can assure you of that.
Thank you, Fatima. Thank you, Chair.
Thank you. Are there any other points for Fatima? No. Oh, Councillor Coates.
Hiya, morning, Fatima. I might be throwing a really radical thing into this. I don't know.
Oh, you've won me over already.
But I'd like to, advocate on behalf of all the women that work in our local authorities. And one hot topic at the moment is like menopause, and how a lot of people, are suffering with symptoms and they don't feel that they get the support from the managers. And I was reading a CIPD report, 1 in 6 people have considered giving up the jobs due to lack of support in the menopause journey. And so we've had a motion recently in Bradford, which I brought forward, and it was supported cross party. So under the heading of women and all things diverse, I'm wondering if there's a policy that you're advocating across our West Yorkshire systems to support these ladies that are suffering and feel like they can't talk to anybody.
So firstly, I knew that I'd like what you had to say the moment you said radical. So I have the privilege of convening the Women of West Yorkshire Network in the name of the Mayor. I'd really love you to join it, and Councillor Rhodes and Councillor Smage and Councillor Jamil, as well as our allies, Councillor Blagborough and Councillor Hutchinson. It's open to anybody who wants to support women. We're meeting next week to talk about the Equity in the North report, which talks about women's experiences, and menopause was a key area of focus. There was also some recognition about the experience of women within the workplace of sexual harassment, of misogyny, and the fact that women have poorer health outcomes because we're disproportionately more likely to have caring responsibilities. So there is so much that we need to work on, Councillor Coates, but menopause is something that we're very much focused on in regards to inclusive workplaces and the Fair Work Charter. So I'm not going to ramble on because Councillor Smage is giving me the look of get to the point, Fatima, we're overrunning. But it's very much on our radar. It will be something that is reflected not only in the strategic vision, but in the practical work of delivering the Fair Work Charter, which is what the Mayor Brabin has been very, very passionate about. But there's also something about how we use influencers like yourself, like Councillor Smage, like Councillor Jamil, like Councillor Rose, that makes this a conversation that we have more openly. Because I think women feel like they can't talk about the fact that the menopause is a medical condition. It is not something that is odd or unusual or a taboo. It is a medical condition and it requires reasonable adjustments, just like anything else. So I could talk about this all day, but being mindful of the time, I wanted to assure you that it's very much on our radar, and to extend an invitation to anybody to come and join the conversation that we're having on Wednesday at lunchtime. To explore the themes of the report and to help shape our aspiration to support women to fulfil their potential. And if we're truly going to do that, then the workplace needs to be reflective of some of the adjustments they may need during the menopause.
That's brilliant. Thank you ever so much, Fatima.
Thank you.
I have to smile at this, Chair, because every time we mention this, then suddenly I can recall other instances, and it's not funny, it's rather serious, because then the next thing we have is, well, the men suffer as well, You've heard that one as well, haven't you?
But I rather hope that the awareness and understanding of the condition and how it impacts people will support men to become much more of an ally in this space. And there's loads of men that are supportive of the Women of West Yorkshire Network, and awareness is the first step to change, isn't it, Councillor Rose? But that's why we have leaders like yourself to influence us and to sort of learn from the areas of the past as well. I'm sure it will be a bumpy ride, but we need your support and leadership.
Yeah, indeed. Information and communication.
That's right. Thank you.
All right. Thank you. Thank you, Fatima, for that. So can I suggest then that you come back with more of a draft strategy when you're a little bit more further along, and also with the review and how that is going and what recommendations are coming out of that, so we can see how the strategy and the review marry together, and what actions come out of that and what progress has been made since the last review, etc. Okay, I think that would be very helpful.
Smage, I forgot to say, and you flagged it because you're always on it, elements that will come through the Donna Kinnair review will be part of the strategy action plan, so they will marry up. My apologies, I didn't make that clear.
No, that's okay, but I think we'd like to understand how that.
And I'd love to come back if I haven't put you off already.
No.
Thank you.
Haven't. No. Okay, so thank you very much for
Thank
that.
you.
I think I think that brings our meeting to a close. So thank you ever so much, everybody, for coming. Our next meeting will be on the 6th of December, and we look forward to seeing everybody then. Thank you, everybody. Bye.
Bye.
Thank you.
Bye.
Bye.
Bye.